Please start, sir. We are live.
Hello, good evening, everyone, and it's a great pleasure to welcome you all for this Lung Cancer Connect, which is now Bhubaneswar Onco Connect, an excellent initiative by none other than the program director. It's a pleasure to invite and welcome Dr. Ghanshyam Biswas, consultant medical oncology. Executive Director at Spurs Hospital, Bhubaneswar. Hello, good evening, Doctor. Hello. Hello. Yeah, good evening, Dr. Biswas. How are you? So we request you to do your welcome introduction and start the proceedings, please. Over to you, sir.
So thank you, Astra, and special thanks to Priyam, thanks to Horizon team, Tarunji and Garima. So today's agenda is we are discussing lung cancer. So in the space of EGFR mutated, so we understand that EGFR mutated has really become complex now. So we started with in our journey in a metastatic disease. Now we know that exon 18, 19, 20, 21. So each of these probably in time to come, or at this moment we are looking them at differently. So either EGFR TKI alone, or in combination with chemotherapy, or in combination with any of these anti-VEGF. So today, to choosing anti-EGFR, so you have to choose it wisely. So looking at the patient comorbidities, patient presentations, whether there is a brain mets or not. Because even in the recent NCCN guidelines for EGFR mutated like ALK, so many of us do a PET CT scan, but still you need to do a CCT brain, preferably an MRI brain, to rule out an asymptomatic EGFR in a EGFR mutated patients, because your choice of therapy will differ. So whether your patient has a EGFR with co-mutations, or these patients have a high PD-L1, so whether you are going to modify your treatment. So whether you are starting with the most potent treatment or not, so or whether you believe in the sequencing, because once if the patient progress, so how much is the T790M activity? So this is going to be dealt with colleagues today. And in the early lung cancer, we know that so lung cancer, even in the early stage, even in stage 1 disease, so we know that only less than two-thirds of the patients are cured in spite of giving adjuvant chemotherapy for post-cycle. So now the horizon is expanding. So if your patient is EGFR mutated, so they can be a candidate for an adjuvant anti-EGFR. So to set the ball rolling, so we'll start with current management and unmet need in early lung cancer. So this will be dealt by Dr. Ganesh Subudhi, who has recently joined with me at Spurs. So over to you, Dr. Ganesh.
Hello. Hello.
So Ganesh, are you sharing the slides or from the technical team?
Technical team can share, or I can share. How to share, I don't know exactly.
So yeah, Garima, so you can help Dr. Ganesh.
Is my screen available now?
Yes, yeah, please go ahead.
Managing, we will discuss. Good evening to all, everybody, and their high esteemed faculties are there. My namaskar to all of you. My first presentation to all of you. Am I audible? Hello.
Yes, yes, very good, very audible.
Good. We'll discuss early stage lung cancer. Early stage lung cancer, it comes to up to 2A, that is up to T2N0, and T2 and local advance, it will come from T2N1 to stage 3. Here we'll discuss a case. 67-year gentleman. He is non-smoker, present with a mild cough. Chest X-ray shown a left upper lobe mass. CT chest showed a lesion in left apical lobe. You can see a left apical lobe lesion. We have patient was initially evaluated with a CT scan, where there is a well-defined lobulated nodular lesion, apico-posterior segment, left upper lobe, adjacent to pleural tracts, suggesting of primary neoplastic etiology. And there is non-FD sub-centimeter prevascular lymph node, which is non-specific. And there is no evidence of anywhere any hypermetallism in the CT scan. What next we should do in this? We can go for imaging. This is small lesion in CT, for looking like T1 or T2 lesion. So in that, we should do a bronchoscopy, or if it's a peripheral lesion, then we will do a biopsy, or if it is central lesion, then we can do a bronchoscopy or EBUS like that. Would you recommend brain MRI CT scan at baseline early stage lung cancer?
Yes, Ganesh.
Any role of pathological mediastinal staging in early lung cancer, before surgery or during surgery, after surgery? Actually, in T1 ABC lesion, we should do stage 1A stage. We should do only bronchoscopy intra. Otherwise, from 1B onwards, so we should upfront we do investigate if there is mediastinal node or not. Accordingly, as per the mediastinal staging, on staging workup, as per stage, we should go ahead with treatment. Here, endoscope ultrasound done, no enlarged mediastinal node, medical fit, underwent surgery. The tumor size is 2.9 into 2.5 into 2. This is a T1 lesion, but there is a visceral pleura involvement. Visceral pleura lesion, that's why it's occurred T2, and there is a lymph node involvement, the T2N1 lesion. Do you check any molecular biomarkers upfront in early lung cancer? Anyone can answer?
No, we usually don't check the molecular markers in early stage.
Right, we do not do actually. But there is a tissue availability issue, as there is a less chance that some tissue will degraded and tissue availability issue. On that basis, should we do?
Yes, I think we should go for that. When there is availability, we should go for molecular study as much as possible.
Otherwise, we do not do. Actually, many of the centers do not practice that. But as a availability tissue, and there is a degree testing of mutation, that frequency decreases. That's why we can do. Which by, if we check, we all check which biomarker do we check for EGF or ALK or PDL? Anyone other?
Sorry to interrupt, Ganesh. So is this your presentation? Because this was supposed to be by
Panel
Soumya.
discussion.
Actually, they said Priyam said this to present.
Okay, I don't know.
This communication, I have sent him 2 slides. I think this is the slides for panel discussion. And his topic was different, sir.
So, should I take up from here on? Easy then.
And then so Soumya sir take up the.
Yeah, I think we can take up from.
So you can go back. So you can go back. So Soumya can. So we can. So by that time, Ganesh, just check out for the right slides. So let us do the panel discussion part. So go to the first slide, please go back. So by that time, you just talk to Priyam, Ganesh, and just check with the right slide set. So somebody,
Hello.
please
Hello.
go to the slides, no, initial slides.
Why should I share the screen if you allow me? Then I can see.
Yeah, please, absolutely.
So Ganesh should stop sharing, or
Ganesh is not sharing, so from the technical team only.
yeah, technical team, please stop sharing so that I can share my screen.
Yes. So let us start with the panel discussion, management of an early non-small cell lung cancer patient. So moderated by Dr. Soumya. So panelists are Dr. Prashant Raghav Mahapatra, Pulmonology AIMS, Dr. Amit Sharma from SCG Cuttack, Dr. Priya Nayak from Some Ultimate, Dr. Sushant Paikrai from SCG, Dr. Prashant Parida from Regional Cancer Center, and Ganesh.
Yeah, thank you, Ghanshyam bhai. So we'll take up this as a panel discussion. Again, we'll come back to the case. I think I'm repeating it, but for the benefit of all the residents that are there in the meeting, we'll take it up first. So he is a 67-year-old gentleman, non-smoker, mild cough, and chest X-ray is showing a small lesion in left upper lobe, and CT chest is showing a lesion in left apical lobe. And these are the images. These already you have seen the images. So and the PET scan that is showing that
Slides are not moving. Please just move the slide. Yes.
is it moving or?
Yes, moving.
Soumya, ये करिए पड़ेगा slide show ही नहीं उसमें अभी.
Just a minute. Are the slides moving or they are not moving?
Perfectly working, sir.
Moving, sir.
Moving. It's okay.
Okay. So this is the CT report, and the CT report is showing a soft tissue nodular lesion in the apico-posterior segment of left upper lobe, and that is the primary neoplastic etiology, and there are subcentimetric prevascular lymph node, and the biopsy is done. Biopsy is adenocarcinoma of the lung. So it's such a scenario. So I'll ask what is the thing that you do across in your lab. So do you go ahead with a further mediastinal staging, and how common is the surgery being done, and how common is the scenario? So we'll start with the senior most faculty and most respected, Dr. P.R. Mahapatra sir. Sir, please can you take up what do you do in your institute? So are you able to do a mediastinal staging in your setup?
Yes, actually we first such cases if you get, normally you don't get such early stage. If it get, we normally we take the opinion of the surgical oncologist, and they used to suggest for medical thoracoscopy or the mediastinal staging, and we used to do EBOS here, and wherever is feasible, that is the standard one. In addition to, I mean, as you already shown that PET CT is already done. If I think that's the only thing EBOS we used to do here.
Right. So Jagame, how do you do a mediastinal staging, and how frequently do you find? I think Jogama is there. She's not there in the panel, but she can take it up. So do you see how many lung cancer has been operated in your center in last 1 year or 2 years?
No lung cancer operated.
It is very rare actually. So
Yeah.
in some dedicated lung cancer centers are there. So, but not in our state. I don't think that we do it regularly. We see it very rarely. Maybe in 1 year we have 2 cases that are operated, 2 to 3 cases maximum. So that is how the frequency is. So with Sushant, you are working in a good comprehensive cancer center. So mediastinal staging, are you able to do that? Sushant, are you there?
Yes, I am here. Am I audible?
Yeah, Sushant, I can hear you.
So we are also in AC. Not done any medicinal staging till now, last 3 to 4 years, and we prefer EBUS guided that staging. And normally we send to the pulmonologist who are able to do the EBUS. So we are perfect with mediastinal staging with PET CT and EBUS guided mediastinal staging.
So do your
So
center have a EBUS? Susanta, EBUS, is your center equipped with EBUS?
we don't have EBUS. We are sending to patients where EBUS available. If
I
available,
think
we will
EBUS is only available at
Correct.
AIMS.
Correct.
not-
Correct.
we send-
So
yes.
correct. So we have only one center in Odisha right now doing a EBUS, that is AIMS, and that was recently that is being done recently. Before also it was not there. So
No.
definitely,
We have been doing EBUS. I think it's almost 4.5 years today. Maybe more than that.
2018,
Right.
I saw that.
And we have been doing it for almost free of cost to all the patients.
That is good. That is good. So I think that is the one of the premier centers in Odisha that has taken that is doing that. So that is a very good news that EBUS is being done. But other centers, other primary centers are not having that facility, which is very much a basic when you start with lung or thoracic oncology. And that is a very big drawback, I think, in our state, that we are not able to do a EBUS as frequently as we would like to do. And so most of the
Sir,
decisions are being taken by based on the PET scan. Yes, Yoga.
Dr. Soumya, I just wanted to ask PR Mahapatra sir that whether they are doing just EBUS guided FNA, or it is a FNA biopsy, or it is a proper biopsy tissue. Just a question.
No, that's nice question. So we have been starting since 2017 May. So we are doing EBUS, not exactly biopsy. We started with the first few cases, and that's we are till now it's continuing. We are doing both cell block and EBUS cytology, both. So cell block, is used for the molecular staging, molecular study, plus and cytology, so that we are not missing. And our result is more than 90%. Even if we are learning curve, it was more than 90% for malignancies. So that means we are doing it regularly, and it is done by our resident also. So it means mostly by resident, and we are done it freely. So it's I mean, say almost every weekly we have 3 to 5 cases weekly we are doing it.
So that brings into the forefront that multidisciplinary team approach. So not only your medical oncologist and surgical oncologist, you have to have a very good pulmonary team to take up a thoracic oncology if proper evaluation, especially if operable. So you need to have a center which does EBUS regularly and EBUS FNA biopsy, and you have to have a good pathologist who does a good reporting.
Yes. Sir, whenever you feel that a patient needs EBUS, you send us, we will give the diagnosis. Patient can go back to you for treatment. There's no issue. So
very good. So sir is very liberal and is very kind on that.
Liberal. We have to be liberal because it's all patient approach. We'll send back the patient to you because you are the treating physician is most. We all respect everybody.
So I think it is opportunity for all of us to hear from sir that we can send our patients to AIMS, and then we can get the FNAB which the patient deserves, and they will do it on the case-to-case basis. So that is very kind of you, sir. So coming to imaging test, so Dr. Priya, so do you do a MRI of the brain in case of in such a case, the case that I had discussed? Do you do a MRI of the brain in lung case, or which case do you reserve?
It is done routinely. Actually, we do routinely. I think that's
routinely.
Yes.
Yeah, routinely we do, but above stage 2, routinely it's like invariably we go for MRI brain. But yeah, in very like early stage, like stage 1 or stage 2A, we can actually let the MRI brain.
So I think that MRI of brain in general in every case, excepting maybe a 1A peripheral location less than 1 centimeter. So these are the areas you might avoid. But I want to ask Priya, suppose you have done a PET CT scan, then still you would like to go to MRI, or are you okay that it is a CT scan, it is included in the PET? So in Odisha, everybody does a PET along with CT. So the CT images are already there with you. So still do you do a MRI, or you are okay with the PET CT scan?
No, in early this lung cancer, if patient is already having a CT brain, then and patient has like PET CT is being done, then we avoid doing a MRI brain again. Because
so most of them are comfortable. If the PET CT is there, then CT is already there with us. So you may not go. But having said that, still MRI is the golden standard. We understand that. Regarding the lab test, so if Dr. Sushant is there, So are you able to do a PFT DLSO, or how do you assess? How does your surgeon assess that the patient is fit enough for a surgery? So they do a 6-minute walk test, or they do a PFT DLSO. How do you do that?
The pulmonary function test, were frankly speaking, I am not doing that. We are assessed that ECG performance status as per the guideline. We are asking whether patient able to climb that is one stair. So if we climb to up to first floor, then we thought it is the performance status is good, and the shortness of breath, the saturation.
So what I understand, Sushant, that you don't have a PFT DLSO really being done, and you base it on the surgeon's, that's operating surgeon's decision that how he will assess. So Prashant sir is there. So
Yes.
I point out, till now we are not able to do a single surgery for lung cancer in our center.
okay.
So
We take a note that. Yeah, Sushant, I will stop you here. So we'll go back to Prashant sir. Sir,
I think Dr. Sushant is right. So that is conventional. I learned from PMH that you kitna सीढ़ी ऊपर जा सकते हैं. So that is standard question, and that is surgeon's perspective. And whenever required, we can do. But there is a issues for that. It's DLCO or that PFT is not like measuring a blood sugar. So it is patient effort is more important, patient understanding of the how to perform test. So it is patient dependent. So we should not too much rely on the pulmonary function test, even if it is available. So it is patient performance status when climbing stairs. So that should be assessed by the surgeons and anesthetists. So it is up to them what they can do.
Okay, sir. Yeah. So the learning point is that. So despite having a PFT and DLCO, whatever most of the thoracic oncology centers, they still rely on the 6-minute walk test or the climbing of the stairs, and they look at whether the patient is requiring extra effort or is taking rest in between, or is he leaning down. So that is the way of functional assessment of the patient, and most of the surgeons, it is a surgeon's prerogative, and they still rely on the old age teaching, and which makes them comfortable in their surgery. So that is what we learn from the discussion. So next is that tissue sampling. So Priya, if you are planning for a surgery in such a small one, and you have got a good CTVS team with you, or a thoracic oncology team with you. So are you okay with the FNSC pre-op, or you want still to go to the biopsy in this case?
Yeah, if biopsy is possible, then definitely I would require a pre-op biopsy. But yeah, if it is not possible, then I would request my surgeons to get tissue.
So
I rely on my
biopsy
surgeons
wherever
itself.
feasible, go for a biopsy. So Amit, you are there. Amit, so in which case will you subject the patient for a mediastinal staging? So patient is having, suppose it is a subcarinal node is there, or multiple into nodes are there, or a single annual node, or which are the patients that you will subject to a EBUS or a mediastinal staging?
I think nowadays the guidelines are pretty clear. I was as soon as I see that this CT scan images, I thought what is the size of this lesion? If it is less than 3 centimeter, can you hear me? If the size of the lesion is less than 3 centimeters, is peripherally then as per ESMO guidelines, you might not need mediastinal. Yeah, but if it is a central tumor and its size is more than 3 centimeters, then definitely I will go for mediastinal staging in those patients. And if patient is already, and there is already mediastinal lymph node, then definitely you have to prove that as well.
Correct. So what I understand is that N0, yes. So I request the tech team to please silent the panelist and the moderator. You can please mute the other speakers. It is disturbing the.
Subhas, mute yourself. Please mute yourself.
So can I repeat my answer, or you understand my point of view? My point of view is ESMO guidelines are very clear. If it is a centrally located N0 on imaging and it is less than 3 centimeter in size, you can directly go ahead with the surgery. If patient has peripherally located, if it is a central located node positive already and it is more than 3 centimeter, you have to go for TBNA first. And if it is if positive in tDNA, then probably media phanoscopy is also needed. If the patient has already N2 node positive, then you still have to prove that with the media phanos staging that it is actually positive. And so only patients where you can actually exclude media phanos staging is those patients who have less than 3 centimeter size peripheral nodule and N0 on imaging.
Very good, Amit. Well summarized. So I think he's pretty clear on that. So when it is T size, it should be more than 3 centimeter central location. And if you have got a N0, N1 or a single N2, your EBUS or a mediastinal staging is compulsory. So if it is a very, very small T less than 3 centimeter, 1 or 2 centimeter peripheral location, then in that particular scenario, you might omit. But otherwise, if it is more than 3 centimeter central location, N0, N1, single N2, go for a mediastinal staging. Very good, Amit. So we'll go to the next slide. Regarding brain MRI and CT, we have already discussed that part. Any role of pathological or mediastinal staging in early lung cancer? Already we have discussed that part also. So it is mostly before surgery, and sometimes during surgery, some thoracic surgeons they do it at the same sitting as well. And most of the centers in Odisha are not doing a mediastinoscopy. We all know that. So tissue already sample biopsy, already we have discussed that we are comfortable with the biopsy rather than a cytology always. And if you have already operated, it is early stage, then definitely you have a lot many tissue for your EGFR and mutations. So this is the NCCN guidelines of 2021. So that is what already we have discussed this part. And this patient endoscopic ultrasound was done, no enlarged mediastinal nodes and medically fit, and patient underwent a surgery. The surgery report, it is a PT2, for size is 2.9 centimeter, N1 because your station 10 and 11 is showing a lymph node metastatic deposits. Coming to the biomarkers, so I will go back to you, Amit, again. Prashant, Dr. Prashant is there. So Prashant, do you do in early lung cancer? So pre-op, would you like to go with?
Prashant has not joined.
Yes, I'm there. I'm there. Yes, I've joined already.
Very good.
Actually,
very good.
I've joined late. Sorry for the late joining. So, of late.
Prashant, I'll complete my question. So when I will talk to Prashant sir, it will be Prashant sir, and when I'll be talking to Prashant bhai, it will be Prashant bhai. So I think we understand that who is who. So we'll come back to Prashant bhai. Prashant bhai, whenever we are going with the early lung cancer, you are seeing such a scan. So pre-op, do you do any? Would you like to do? Are you attracted to the PDL1 testing or any EGFR testing, or you are going at okay, we'll go to the surgery and after that we'll go with the. So how
previously in early stage lung cancer, there are no data regarding the EGFR TKI like osimertinib or atezolizumab. So previously I was not doing any biomarker like EGFR or PDL1. But of late, even I have advised, we rarely see a early stage lung cancer either for neoadjuvant or adjuvant therapy. So I have advised one or two patients. So I have started doing EGFR, especially EGFR and PDL1, not others. But these two, if someone having stage 1B or more than that, I am doing EGFR, and for stage 2 onwards, I am doing PDL1 also.
Okay, so I think that the message is pretty clear that after the ADORA trial, so most of the physicians they are more comfortable in doing a EGFR. ALK still it is not means in the guidelines. So ALK we are not doing that. Other markers we are not doing that. Regarding PDL1, it is an evolving area, and we will discuss the data subsequently. So do all the patients in early lung cancer undergo surgery? So neoadjuvant chemotherapy, just yes or no? Do you practice yes or no? Sushant, have you ever given a neoadjuvant chemotherapy in a lung cancer?
Yeah, I have given sometime we discussed with surgeon. If we are not willing for surgery for initial things, then we can give neoadjuvant at that setting. If you go that with guideline, then in specifically T3 and that N1 or N3 lesion, sometimes we have to give NACT followed by we go for surgery or CTRT. At that case.
So I'll come back to Prashant bhai. Prashant bhai, neoadjuvant chemotherapy. do you practice? Means have you done and in which stage?
So I have given neoadjuvant, especially stage 3, stage 3A or 3B. But
yeah, so we'll not discuss further. I think they are pretty clear that 1, 2 you can operate. 3A is the area where you mostly practice in neoadjuvant chemotherapy, and 3B very rarely or almost not there. So 3A is the area of target, and of course, as Sushant pointed out, it has to be discussed in a multidisciplinary team, and your thoracic surgeon has to take a call that whether he wants to go ahead with the neoadjuvant chemotherapy. So we'll not. So percentage of undergoing resection, I think all of us agree that it is very less. In Odisha, most of the patients means they come in advanced stage. And what are the possible reasons? Location and other education, delayed presentation. So that is a very vague kind of answer to that. What are the possible reasons for the delayed presentation? What factors should be considered in determining resectability? Already we have discussed that part. RT, very valid questions.
Dr. Somya, I have an answer to that. So we go neoadjuvant as per this uses of the surgeons and radiotherapy, because they want that at times, that getting a date in surgical oncology get delayed. If Dr. Madhavanandakara wants that I will operate this person and give some chemo, and we don't have any thoda chota ho jata, to hum dekh lenge aage. So used to go that, and Dr. Saurabh Majumdar also used to say that chemo 2-3 cycle de do, uske baad radiation area bhi kam ho jayega. I think we don't have.
I agree to that. That call of surgeon is very important, and his decision on the surgery part is again decision is very important. So I think we very much accept your point, sir, that it is a very valid area.
Sir, if you consider my institute, the only option in my institute is chemotherapy. Whenever a lung carcinoma comes to us in HPGIC, so they will land up with medical oncology. So the guideline says differently, but practice may differ from our.
Prashant Bhai, will come back to you. Prashant Bhai, RT, post-op RT, where do you practice post-op RT?
So especially in margin positive cases. So incomplete resection, margin positive.
Leaving out margin positive, any other patients that you subject to a post-op RT or no RT?
So especially in high risk factors, because we rarely see a case of otherwise when you are considering a definitive chemoradiation, that is another indication. But in
so I think you have answered it correctly only. So most of them stick to, if margin is positive, then we deliver a post-op RT or we send it to our radiation oncologist. Otherwise, CTRT is the area where we look. So Amit, which patient will you like to discuss with your radiation colleagues for SBRT?
Definitely the patients who is unfit for the surgery. I personally early stage 1, stage 2, peripherally located patient and basically unfit for surgery, and patient doesn't want to do surgery. So these are the two conditions I probably look for. The SBRT, XBRT gives equal results with the surgery in the early stages. And I think that these
very
are
good. So I think the summary is that peripherally located, small one. And then in that case, you will go with it. So this patient is a stage 2 adenocarcinoma, and molecular panel has come that patient has undergone a surgery, and the report has come EGFR mutant L858R. So adjuvant chemotherapy, osimertinib. So we'll take up first with Dr. Priya. Priya, adjuvant chemotherapy, yes or no? And
in this case, if it is EGFR positive, we should, as per data, this ADAURA trial showing very good DFS and this OS also. So we should go with this osimertinib. I mean, as per data.
Correct. So I agree to that. Osimertinib is there in the plan. We'll come back to the discussion on the other part. Yes, osimertinib is there in the plan as per the ADAURA trial. OS part we'll discuss later. So Prashant sir, chemotherapy, do you give chemotherapy in this patient looking at the EGFR, or we'll just go ahead with the osimertinib? So it is chemo plus osimertinib or only osimertinib?
So in such cases, actually early stage lung cancer is very rare. We used to go according to wishes of the other oncologist, and normally if we suggest osimertinib, but practically have truth that most of the patients come to us, they usually do not, very few patients afford osimertinib, and most of the they used to start erlotinib on those patients.
So I think that the other TKIs, we have got data from the Sitong about the Gefitinib, the Erlotinib also data is there. But since this is a panel discussion and scientific forum, we'll restrict to the osimertinib views from the ADURA trial. And regarding Amit, so chemotherapy, yes, no, or only directly osimertinib?
Even in that ADURA trial, 60% of patients also received chemotherapy, and in that patient, actually the result was irrespective of they have not randomized the stratification was not done between patient who received chemotherapy or do not receive chemotherapy, and actually patient who received chemotherapy, the hazard ratio was better than those patients who did not receive chemotherapy. So I would go with adjuvant chemotherapy along with osimertinib for 3 years.
Very good. So Amit, to update you, so there is a data that in the subgroup analysis they have seen that whether you give chemotherapy, you don't give chemotherapy, your hazards are very, very close to each other, and that do benefit. And as per the standard, since we are giving chemotherapy, and 1 to 4 cycles was there in the trial, so yes, chemotherapy plus osimertinib will be the ideal way to go about, as you mentioned. So benefit of adjuvant chemotherapy already we have discussed. So I'll just take one word from Prashant Bhai. Prashant Bhai, adjuvant chemotherapy, only one regimen, cisplatin, carboplatin.
Cisplatin plus pemetrexed, because it is adenocarcinoma. I will prefer cisplatin plus pemetrexed. If performance status is poor, or then I can go for carbo. Otherwise, cisplatin pemetrexed will be my standard adjuvant therapy. Previously, we were practicing platinum mineralization.
Anyone else has to comment? Then
like I used to prefer this cisplatin and vinorelbine combination as an adjuvant setting.
Correct. So I think vinorelbine and cisplatin has got the the longest data, and most of the adjuvant was on vinorelbine and cisplatin. Newer data, pemetrexed cisplatin feasibility is there. So vinorelbine and cisplatin is mostly the data is there for that from all the randomized trial. And regarding carboplatin, it is still cisplatin. And the benefit of adjuvant chemotherapy that increases as the stage increases. So 1B, 2, 3. So the numbers of the benefit increases. Now coming to the
Soumya, we need to wind up. Soumya.
Yeah. So ADURA trial, we have discussed this very important trial. So the hazards are such that the hazards are very, very strong, and it is something like 0.17, 0.12. So with these kind of attractive hazards, so most of the physicians right now, if you are EGFR mutant, then we do practice osimertinib. And the recurrence part after osimertinib, it is mostly local recurrence. So that is again regarding OS, is the ADURA practice changing? All of the oncologists will agree to that. Yes, ADURA is practice changing. And with that, I conclude my slide and hand it back to Ghanshyam Bhai. Thank you everyone.
Thank you, Soumya and the panelists. So now we go back to the first session again. So if Ganesh is ready, so current management and unmet need in early lung cancer. So Ganesh and Chinmay will also give that inputs what Soumya has talked about. So we'll see more about ADURA. So Ganesh, so over to you.
Is my screen visible to all?
Yes, visible.
We'll discuss current management and unmet need for in early lung cancer. Lung cancer, as per Global 20, there is greatest number of deaths all across. Am I visible?
So you have to say next. So if you want to change the slide, next.
In early stage, actually, there is 1/3, 3, 1/4 to 1/3 cases we see early stages. Usually in India, we see it's mainly local, mainly metastatic disease, and up to 25%, 22% cases we see is local advanced disease. Resectable lung cancer is 1, 2, and stage 3A. Stage 1A is T1N0, 1B is 3 to 4 symptoms, basically N0 disease. T2A is and T2B N0. This is at 1A to 2A is actually early stage disease as per NCCN, and 2B onwards N1 disease becomes local advanced disease. Here we see we assess the resectability status. Multidisciplinary approach is needed. Generally, before that, we to diagnose and staging, there is non-invasive modalities and there are invasive modalities. First of all, patient come with a chest X-ray from periphery, and on higher centers like us, we do CCD chest and upper abdomen. We evaluate for any metastatic disease. Otherwise, you do a directly PET CT. Affordable patient is there. And from stage 2 onwards, MRI brain is recommended. So we do the MRI brain. And from invasive modalities are required as there is mediastinal sampling and mediastinal staging. In 25 from stage 2 onwards, stage 1 to stage 2 to 3 onwards, so we see there are of staging. So we do invasive modalities for mediastinal sampling or dissection. Bronchoscopy, we do pathological mediastinal lymph node evaluation, EBOS and mediastinoscopy, and thoracoscopy. Multidisciplinary involvement is required. Should we assess the suitability? Mainly surgeons assess the suitability by doing PFT, FEV1 and DLCO. If greater than 60%, no further test is required. But if there is a less than 60%, greater than 30%, we do stage clamp test. Just we have discussed. Stage 1 to directly we do surgical resection. After stage 3A, we can go for surgery. There are multiple way of doing surgery: lobectomy or segmentomy and orgy resection. One second. If stage 1, we do mediastinal sampling. From stage 2 onwards, or there is we suspect lymph node involvement, then we do mediastinal dissection. And in a meta-analysis, after system mediastinal dissection, it is small to moderate improvement survival benefit. So we can do lymph node sampling in stage 1, and stage 2 onwards we do mediastinal dissection. Approach for surgery. Now the surgery advances there. Open thoracotomy, VATS and robotic assisted surgery, and we avoid actually open thoracotomy now. We do VATS and robotic assisted pulmonary dissection. The advances VATS and robotic assisted surgery actually solve many problems. Decrease ICU hospital stay and less recovery and less blood requirement. Previous surgery is too much for the patients. VATS where we do, there is an anatomy lobectomy, individual hilar ligation, complete hilar lymph node dissection, no rib sparing, no rib spreading actually, incision size is less. So there are a lot of advantages in VATS. Now in high volume centers, there is VATS we are doing, and with less morbidity, including perioperative pain and surgical morbidity are less. But 2A to go for VATS, there is a 2D vision, lack of depth of perception, rigid instrument with counterintuitive movements, poor ergonomics, and there is long learning curve. Advantage of robotic surgeries. There is minimal assist surgery, complex operation possible, reproducibility, assess the inaccessible, shorter hospital stay, early return to work, less blood transfusion, less pain. So we are moving for with robotic surgery and hearts. What are the advantages? There is a long-term survival in stage 1, 63 to 92 97%. Recurrence is less, 5 to 10%. Lymph node clearance is more or less equal to open surgery. Robotic pulmonary resection gaining wide acceptance in terms of safety and oncological accuracy. So, this is the flow chart how you proceed with your local disease and local advanced disease. Stage 1 to 2, if surgical candidate surgery fit, then we do a surgery and pathological staging do. If not, do upfront do SBIT or definitely IT we do. Pathological we can after surgery we can give for follow up with this observation. If there is margin positive, we will think about radiation. Otherwise, up to stage 2, 3, there is adjuvant role of adjuvant radiation and chemotherapy. And clinical stage 3 is multidisciplinary approach. We do mediastinal dissection and as per stage we do concurrent chemoradiotherapy. There is actually from stage 2B and high risk factor, there is role of chemotherapy. Otherwise, there is no role of chemotherapy in early disease. There is less of data in early disease, any adjuvant and new adjuvant. If you like discussed earlier, if surgeon is saying that the size is a little more, reduce the size, make it operable, then we do new adjuvant. Otherwise, do not give new adjuvant chemotherapy. Lung cancer is responsible for greatest number of death, less than 10%, which is in stage 1 and 2. There is multidisciplinary involvement. There are multiple methods for operating lung cancer. Open and VATS, robotic VATS and robotic are now gaining the momentum. So there is a higher center where VATS and robotic surgery are done, then we send patient for there. Post-surgery outcome lung cancer continue poor with 40 to 70% recurrence. So we need follow-up with that. Osimertinib adjuvant like DFS Aurora trial, which is the DFS advantage is there. So and local recurrence is less. So there is gaining of adjuvant osimertinib. Thank you.
So thank you, Ganesh. So that brings us to actually Adura. So where Ganesh left. So new paradigm in treatment of early non-small cell lung cancer. So Dr. Chinmay will talk about Adura trial in details. So over to you, Dr. Chinmay.
Thank you, Ghanshyam bhai. Thank you, Astra, to take an initiative for the spread of the information. And the adjuvant therapy in the lung cancer getting crowded. Ganesh, can you let me to share my screen? I'm not able to. Kindly unshare, please. Can you unshare or stop sharing your slide, Ganesh?
1 minute.
Yeah.
I think now you are able to share.
Just one
We are still viewing Dr. Ganesh. Unshare.
Unshare कर दो.
Is it okay?
No. ऊपर में है unshare का option. Check कर लो.
Or it's saying resume share. Means I am now not. I am not sharing.
No, but we are seeing your slide.
Is it okay?
Oh, okay. Is it okay
Yes.
now? Okay. Sure. Yeah. I think I'm audible and my slides are visible. Okay. Sure. So Dr. Soumya and Dr. Ganesh has actually put a very firm base to discuss in detail about the Adora trial. So let us dissect the Adora trial in a proper way. So first thing is that almost NSCLC, 85% of all cancer cases, lung cancer cases, and an estimated 30% at the present with the presenting with a resectable diagnosis. So there is a localized or early stage disease, stage 1B, regional or locally advanced is stage 2 and stage 3A. And we know that surgery is the primary treatment for the early stage NSCLC. And as per the analysis, let me say meta-analysis what has been shown, the adjuvant cisplatin-based chemotherapy is recommended in patient with stage 2 to stage 3 NSCLC and in selected patient with the stage 1B disease. But recurrence is inevitable, and if you see the recurrence rate in stage 1B, it is 45%, 5-year recurrence rate, stage 2, 62, and stage 3 is 76%. So definitely there is an unmet need for development in the curative setting in case of the early disease or the locally advanced disease. If you see the slide, the overall estimated prevalence of the EGFR mutation in the stage 1 to stage 4 is in the range of 30 to 40% in the Indian subset, and in the Caucasian it is 10 to 20%. So if EGFR TKI were available in the resectable setting, a similar proportion of patient may benefit, as in compared that we can extend that the benefit what we have already got in the advanced setting. So from this context came to the ADAURA. So osimertinib and adjuvant therapy in patient with stage 1B to 3A EGFR mutation positive NSCLC after complete resection. So the key inclusion criteria are the patient those who are more than 18 years of age, primary NSCLC non-smokers, post-operative stage 1B to 3A, with a confirmation of the exon 19 deletion and L8 by EGFR mutation. The standard, some patients got the standard post-operative adjuvant chemotherapy, but that was not mandatory. Complete resection is fine. An MRI and CT scan has been done prior to the surgery, and they are of good performance status. So the exclusion criteria, the patient who had actually segmentectomy or the wedge resection have been excluded, and they have prior treatment with pure post-operative radiotherapy or pure operative chemotherapy. When they have done the stratification from the stage based 1B versus 2 versus 3, EGFR mutation based, Asian versus non-Asian, and the dose 8 mg once daily what you do, and followed by the placebo. The primary endpoint was the disease-free survival in the stage 2 to 3A, and the secondary endpoint is the disease-free survival in the overall population. That means 1B, 2, and 3A, and DFS at 2, 3, 4, and 5 year, overall survival, safety, and health-related quality of life. So if you see the patient characteristics, so almost equally balanced. The EGFR mutations of exon 1955 in both the group, adjuvant chemotherapy ESN 60-40 in the both the group. There is minor change. Asian populations are more also well balanced study, I can say. When they analyze the disease-free survival from the stage 2 to 3A, so in the osimertinib, there is not the DFS is not recordable versus the placebo 9.6 with hazard ratio of 0.17. When they see the overall population with all patients, including the 1B, and it is hazard ratio is 0.2, and here also it is not raised. So the 2-year DFS when they calculate in the stage 1B, the osimertinib versus this, the hazard ratio is 0.39. In the stage 2, it is 0.17. In the stage 3A, it is 0.12. When they analyze the subset analysis by male or female, age less than 65, more than 65, smoking history, Asian, non-Asian, without stain, any mutation present, adjuvant chemotherapy taken or not taken, across all subset, osimertinib is proven to be better. And this is the data of the 2-year overall survival. The 2-year overall survival actually not raised in the both group, and that is the data with the hazard ratio of 0.4. This is the early 2-year data what they have shown to the picture. But what has been done from the previous EGFR TKI? So this is the part of where they have shown a significantly disease survival across all groups, and also an overall survival at 2 years, but 3, 4, 5 years yet to come. So I'm not going to that. So let us see how the previous EGFR TKI have been so. In the SELECT trial, they have taken stage 1 to stage 3 EGFR mutant, erlotinib after the adjuvant chemotherapy plus mensatinib, 2-year disease survival of 88% versus 76% of the historical control. Radiant trial, stage 1B to 3A, EGFR expression and amplification, erlotinib versus placebo after adjuvant chemotherapy, clinically meaningful DFS improvement 46.4 versus 28.5. Evans study, erlotinib versus adjuvant, but it is stage 3A, EGFR mutant, significant DFS 42.4 versus 21. Wow. And the adjuvant, the CTONG 1104 trial, stage 2 to stage 3A, N1 to N2 EGFR mutant, Zefnib versus adjuvant, significant DFS improvement, no OS. So VR19, so stage 1B to 3A EGFR unselected, Zefnib versus placebo after adjuvant chemotherapy RT, no DFS, no OS. So somebody has given a meaningful benefit, somebody has given a significant DFS, but nobody has given overall survival, though it's in early data, overall survival has been seen, and also DFS is seen across the all group. So let us see the type of recurrences. So first is the local or regional recurrences has a better survival than the distant recurrences. And also CNS recurrences is an unmet need that we'll see. So in the ADRA trial, see the left one. So here 11% recur and the 62% are the local recurrences. In the placebo arm, 46% recur, but 61 majority are the distal recurrences. That's the point number one. So it increases the local recurrences where the management is better or survival is better than the distant recurrences. Point number two. Point number three, if you see the site of recurrences, so how the recurrence has been reduced. The percentage of recurrence that is mostly reduced in the CNS recurrences. In the placebo arm, it is 10, but in the CNS arm, in the osimertinib arm, it is 1, where they have the recurrences of any location, they have significant reduced, 46 versus 11, lung 18 versus 6, but significant, like 90% recurrences have been decreased by at the CNS, and so also the bone and other. And if you see the ADAURA CNS event analysis, in the osimertinib it is 6% versus the 39% in the placebo, and the CNS recurrences in 4 and other are at death they have commenced, the data have been commenced. So in the CNS disease-free survival, if you analyze in the osimertinib, it is not this versus placebo, it is 48.2, which is quite significant of hazard ratio of 0.18, irrespective of the stage, irrespective of 1B, 2 or 3, overall population. So if you see the safety summary, so adverse event possibly causally related adverse efficacy, the grade 3 adverse event are around 32, that is 10% of cases versus in placebo 3%, but leading to death is 0. And we all know the problem with associated with osimertinib are diarrhea followed by paranoia, dry skin, pruritus, cough, stomatitis. But the problem which is life-threatening is maybe a QT prolongation and maybe interstitial lung disease, which is very less, but you need to very stringent. The grade 3 and grade 4 problems happen in the stomatitis and also in the diarrhea. These two components, they have the grade 3 and grade 4 problem, and we need to manage. So, and median duration of osimertinib is 22.3 months, and we know this as a class effect, what we have done in the metastatic setting. So this is the updated data, those patients who have got post-operative chemotherapy and followed by the osimertinib from the ADRA trial. So let us analyze this. So out of the 682 patients, 60% patients receive adjuvant chemotherapy with a median durations of 4 cycles, and majority receive the platinum-based chemotherapy, most with stage 2 and stage 3 disease, and few with 1B disease. And so one patient got the single agent pemetrexed only. So adjuvant chemotherapy is most frequent and the less than 70 years of age. If you analyze the patient received adjuvant chemotherapy in stage 3 is 80%, 2 71, and 1B is 26%, and these are the descriptive analysis. So the DFS in overall population with and without adjuvant chemotherapy. If with adjuvant chemotherapy, 89% versus 49%. If you see this is the data of 24-month cutoff, And if it's the DFS median month, it is osimertinib not traced versus the placebo is 22.1 and hazard ratio is 0.16. And when you see without adjuvant chemotherapy, the hazard ratio is 0.23 and it is not recorded, sorry, not traced versus the 33.1. Second, and when they analyze the data, whether the stage 1 and stage 2 without adjuvant and with adjuvant chemotherapy favors osimertinib. Stage 1B without adjuvant chemotherapy favors osimertinib. Stage 2 with or without adjuvant chemotherapy favors osimertinib. Stage 3A with adjuvant and without adjuvant chemotherapy favors osimertinib, not the other one. Okay. So DFS in the patient with or without adjuvant chemotherapy in stage 1B, if you see the stage by stage 1B in the osimertinib, not is versus 48.2, so hazard ratio not counted, and without adjuvant chemotherapy, so it is 0.38, and both are not raised. It in the stage 2 with adjuvant chemotherapy and without adjuvant chemotherapy when they analyze, so with it is not risk versus 29.4, hazard ratio 0.15, and in the without adjuvant chemotherapy it is 0.2, hazard ratio is 0.2, so not risk versus the 22.1. In the stage 3A with adjuvant chemotherapy the hazard ratio is 0.13, and here without adjuvant chemotherapy it is 0.1. So finally, so finally, with or without chemotherapy, the effect is significant and beneficial. That will conclude later on. Then second one is the patient-reported outcome from ADURA in the segment. So they have analyzed the SF-36 questionnaire from physical functioning, from the role of physical, bodily pain, general health, vitality, social functioning, emotional, and mental health. So with each domain, they have created a 36 questionnaire and they have collected the data from start, randomization at 12 week, 24 week, and every 24 week, and up to the treatment comprehension for the 3 year. So till now they have analyzed and they have seen over the time the compliance rate is quite high. So median durations of total duration exposure in 22 months with osimertinib with 18.7 months in the placebo. That means the adverse effect what you are seeing, that is not been reflected here in the quality of life, that I want to emphasize here. And so also the time to deterioration. So during the disease-free period, the majority of the patient did not have the meaningful deterioration in the physical or in the mental. So that's the point to be noted. So to summarize, so adjuvant osimertinib is the first targeted agent of the global trial to show a statistically significant and clinically meaningful improvement in the DFS in the stage 1B, 2, and 3. The overall 80% doesn't risk of recurrence or death with osimertinib. So the osimertinib versus placebo DFS were 89 versus the 52. Adjuvant osimertinib, a clinically meaningful improvement in the CNS DFS compared to that of placebo. I can say it's 90% reduction. And the safety profile, and with hazard ratio of 0.1, it's the lowest hazard ratio. So the toxicity profile is consistent and established what you are seeing in the in the metastatic cases. And the clinically meaningful DFS benefit in the osimertinib was observed in the patient with or without adjuvant chemotherapy, regardless of the stage. And the higher disease recurrence were observed in the patient, the placebo arm, who received adjuvant chemotherapy compared to that who did not. And overall, the quality of life is maintained with adjuvant osimertinib with no clinically meaningful differences versus the placebo despite the prolonged treatment. So adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, and 3 EGFR mutated NSCLC after complete tumor resection. Thank you.
So thank you, Chinmay. So not only the adjuvant osimertinib with or without chemotherapy post that. So not only the quantity of life, but the quality of life is also taken care of. So we know that now there are 3 generations of anti-EGFR. So with that, the efficacy has improved, the CNS penetration has improved. So Sushant will speak on evolution of TKI and current treatment outcomes in first-line EGFR NSCLC.
Yeah, I'll share my slide. Is my slides visible?
Yes, sir.
Okay. Now it is full screen. Okay. Then after long discussion as that early stage lung cancer, that in detail, the stage 1, stage 2, and stage 3, all the things we discussed. But the thing is that the practical thing is that we are not seeing this type of patient at the early stage lung cancer in our practice. Last 3 years, I have seen that most of my patients have lung cancer are very advanced. So around 60-70% are they are belongs to the stage 4 or stage 3 are very much advanced. So now discuss evaluation of TKI in current treatment outcomes first line EGFR positive NSCLC. We know all the things it is discussed early. The new thing is that that ADORA trial that we can give the osimertinib in EGFR positive in initial stage. So we have to review what are the advantage of that EGFR anti-EGFR agents. So we need not to discuss much about that incidence. All we know that lung cancer is one of the most common cancer along with mortality also. So it is the most common in common overall incidence rate among the cancer patient in India, and second most cancer in males and sixth in females. And here the male female ratio is 4.5:1, and smoker non-smoker ratio is 20:1. So as you see, here the what is the need of discussion? We know that in stage 4 there is 5% overall survival rate, but along with EGFR TKI, if it is EGFR mutation positive, then we can increase to the 15%. So this is the data how to use the molecular targeted therapy in metastatic lung cancer if there is EGFR mutation. No doubt, along with first generation, there is third generation osimertinib we can give. We'll discuss later. And therefore, ALK positive and ROS1 we have to the guided by the targeted therapy. If there is no target positive and PD-L1 expression, then we can use pembrolizumab. And if all the things along with PD-L1 negative, then we can use chemotherapy in that case. So this is the guideline how to what are the category 1. The preferred is osimertinib and other agents can be used. And if there is financial constraint, it is all the erlotinib, apatinib, dapatinib, dacomitinib, all the category 1 along with the osimertinib. So we'll discuss one by one. The erlotinib and dapatinib is the first generation TKI. It is the EGFR inhibition along with mutant EGFR. It can binding to the wild type. Another thing, it is reversible binding. So it is it is inactive on P790 mutant. So erlotinib dapatinib is first generation TKI and it is reversible binding. So the action is not long standing. Coming to second generation, it is the apatinib and dacotinib. It is irreversible covalent binding to the EGFR, that is other EGFR2 also, and also ERBB4. So it inhibits all the family of EGFR agents. So there is more side effect with second generation TKI. Coming to osimertinib, it is third generation. The important thing about osimertinib, it is EGFR mutant specific inhibitor. It is only bind to EGFR, the mutant, the pathogenic mutant EGFR receptor, and it is wild type sparing. So it has less side effect compared to other that is other EGFR TKI. So it is also irreversible covalent binding to mutant EGFR, and is also active in P790 mutation. So here is that hypothetical advantage of osimertinib. Why we prefer osimertinib. Coming to data. So here is the IPAS study, which is the landmark study for metastatic lung cancer. Before that, we thought lung cancer is very much short survival, because in we predict if we previously before the TKI we predict that is 6 to 12 months of overall survival of stage 4 cancer. After this IPAS study, our concept was changed. about the metastatic lung cancer. And here in this study, they include all type of adenocarcinoma patients, and they saw that most of the definitely have advantage in EGFR mutation subgroup. Then the concept of using of EGFR TKI came. So coming to discuss here, we know already it is discussed. It is that the PFS was 24.9 versus 6.7% in Japanese. Here it is in all subgroup because you have advantage because most of patients are the Asian patients. So we predict that among the Asian, we know that it is the EGFR mutation is more positive. So it has PFS advantage. But whenever they divide the groups, EGFR mutation positive groups and negative group, it is the Japanese only advantage in EGFR mutation group. The PFS advantage is seen. So, but there is no OS benefit even if in EGFR mutation positive group. So there is no OS advantage of Gefitinib. Then coming to Elotinib and Afatinib, this is the Elotinib data. It was optimal and all have PFS benefit, but there is no OS benefit. Coming to Afatinib, it is second generation TKI. The Afatinib has significant prolonged PFS. That is 11. The whenever compared to Afatinib compared to chemotherapy cisplatin pemetrexed, that is 11.1 versus 6.9 with hazard ratio 0.58 with significant p value. So we know that it is the PFS was significant if compared to the chemotherapy. And coming to the gemcitabine, another arm is gemcitabine cisplatin. Here is the same, that is 11 months versus 5.6 months with hazard ratio 0.28. Then that is another study that Lux Lung 6. They compare that is they OS did not differ significantly between two treatments because here they compared with afatinib and cisplatin pemetrexed. They did not find any advantage over in overall survival. So in both the group, in gemcitabine cisplatin also, they did not find any significant median OS benefit. Coming to when they compare with afatinib with gefitinib, they found there is median PFS is 11 months and versus 10.9 months. Only 3 months of advantage, but it is significant with hazard ratio 0.73. Here also they did not find any overall survival benefit. Coming to HCR 1050, that is about dacometinib, another EGFR TKI, second generation TKI. They use dacometinib versus gefitinib. The primary endpoint is PFS and secondary endpoints were OS and PFS, investigator associated, and overall response rate. Here they did not include no that is brain metastatic patient. Here also they found PFS benefit. It is 14.7 months versus 9.2 months in gefitinib arm, but there is a late separation of PFS curve. So subgroup analysis of PFS suggests that efficacy was greater in Asian groups. Then coming to overall survival, here if we analysis only overall survival, then there is difference. That is that 41 months versus that is 33.6 months in gefitinib arm. But whenever they going to another that relate with PFS data and the overall response data, they did not find any significant OS. It is called hierarchical testing, where we have to analyze it step by step. We include all the data of PFS and overall response rate, then finally we analyze OS. There is a statistical method to conclude whether our OS is really significant or not. Then this is the summarization of all the TKI. We know there is overall response rate about 71 to 75%. In elotinib afatinib around it is 60%, and median PFS that varies from 15 months to 10 months. but there is no OS benefits. And the first and second generation EGFR TKI have shown significant PFS, but none of them show significant OS benefits. Here also there is grade 3 side effects in first generation is 45%, in afatinib it is 49%, dacotinib it is 63%. If we consider our FLORA trial in Jepitine Melon, it is 37%. So it shows almost half of the patient having the grade 3 side effects. Coming to summary, that first generation and second generation EGFR TKI have shown significant PFS in metastatic EGFR without any OS benefit, with adding toxicity in second generation TKI. So coming to osimertinib, the third generation TKI, more specific EGFR TKI, it is on FLORA trial. We analyze the final overall survival data. So this is the trial design. That is, they include histology performance status 0-1 with EGFR mutation and no prior systemic anti-cancer therapy or EGFR TKI, and they also allowed stable CNS metastasis. In other cases, they are not included CNS metastatic patients. So osimertinib here is 80 mg per oral per day, compared to EGFR TKI, Jepitine and Elotinib, and the primary endpoint was the PFS, and the OS was the key secondary endpoint. Here the baseline characteristic, all the groups are equally divided. Here the PFS analysis, here PFS was significantly better in osimertinib compared to first generation TKI, 18.9 months versus 10.2 months, with hazard ratio 0.46 with significant p-value. And osimertinib favors in all groups. You see that on the forest chart, there's no one crossing the midline. So all the groups is benefit with osimertinib. Coming to group of CNS metastatic patient, here also osimertinib having significant benefit. Here the median PFS CNS in meds, there is that is not reached compared to in Sopotibar 13.9 months, and the hazard ratio 0.48, median follow-up months 12.4 months in osimertinib group, and Sopotibar physician choice group is 7 months. So here the CNS progression rate, it is the osimertinib, the include 279 patients. Here the we see the progression is more in standard EGFR TKI compared to osimertinib group. So it is the CNS progression rate more in first generation TKI. The final analysis about OS, that is 36.6 months. 36.6 months. So here also the hazard ratio 0.79 with significant p-value. This study only showed us that osimertinib, the TKI, anti-EGFR TKI, having the only agent showing the overall survival benefits in all groups of patients, including CNS mets. So here also overall survival in the curve also it favors all the subgroup. Here only the ASEAN subgroup, they cross the midline, but except that all the things they have great benefit with anti-EGFR TKI. Some patient L858 mutation also cross the midline, and otherwise it is that as data shows that you have significant overall survival benefit in all the groups. The subsequent treatment related death, here the osimertinib, that the time to fast subsequent treatment is also significant. There is in osimertinib bar, that is therapy, that is 194 events compared to EGFR TKI, there's 242 events. So as events less, it is definitely it is very much significant overall survival with significant p-value with hazard ratio 0.478. Then the second line of treatment on progression, we saw it is the delay in the osimertinib arm compared to other EGFR, the comparator EGFR TKI. So adverse events, we see that osimertinib arm, there's diarrhea seen in 60% compared to comparator EGFR TKI, it is 58%, and rashes also 59%, but more seen in the first generation comparator TKI. So if we compare the side effects, it's not much, but if practical experience, we ask me here, we have many patients with osimertinib. We see less side effects. That is the skin, the nail toxicity, and diarrhea is more less in osimertinib compared to first generation TKI. In conclusion, FLORA showed a statistically significant and clinically meaningful improvement in OS with median OS of patient. The osimertinib arm was extended to by 6.8 months. Osimertinib is the first EGFR TKI monotherapy, so statistically significant OS benefit. Along with this, trial included CNS metastatic patient, and the final OS analysis of FLORA reinforces in osimertinib as the standard of care for first-line treatment of patients with EGFR mutation advanced non-small cell lung cancer. Thank you.
Thank you, Sushant. So now we move to the next topic. So how do you optimally manage EGFR mutated non-small cell lung cancer? So Prashant Parida.
Sushant, please on share. Please stop sharing. Sushant.
I already stopped share.
Okay,
My screen is visible. I don't think.
Actually, I'm not yet able to share my.
I immediately stopped my sharing. I want to finish my slides very early, not to delay much. Now your screen is visible. Prashant sir, bhai, your slide, now your screen visible to us. There are a lot of your.
Can you please stop share? I will share your slides.
1 minute, please. Okay, please share my slide. Actually, I am not able to see my slides also.
एत्ते गौरी अच्छी डेस्कटॉप का मुश्किल
है.
Prashant, you stop sharing, no? So the Garima,
Yes,
Garima will share them.
Yes, bhai, I have. Yes, I have already stopped sharing. Please share my slides.
Is someone sharing the slides?
Garima, please share my slides.
Are you listening, Garima, Tarunji, Priyam?
Yes, sir. I'm just calling them. Just a second, sir. So she is sharing. Just a second, sir.
प्रशांत तुम स्लाइड कौन मिलनी है ये कौन है
से कहीं मिलूनी मत भाई मु देखुची कहीं
भाई करे इतने डेस्कटॉप रे इतने प्रेजेंटेशन में इतना प्रेजेंट करते हैं भाई भूली तो
कहीं पाऊं
भाई डेस्कटॉप को क्लीन
आज
रखिए
हमारा आचार्य रे प्रेजेंटेशन थला जे मु सेठी so bhai I can start so it is very difficult to optimize because now we have problem of entities especially in advanced non-small cell lung cancer we have almost 5 TKIs approved though osimertinib is the preferred agent still we have other 4 agents most of us have used and also patient get benefit from all other TKIs. So osimertinib is the preferred frontline TKIs. Even we have several data regarding the TKI plus chemo combination. Our own TMH data, even Biswas bhai can say better, OS is almost 51 months. Even the relay trial, you can see the bevacizumab erlotinib, especially in L858R, where the PFS is almost 18 to 19 months. Even one of the Japanese trial where they have combined dapitinib with chemotherapy have got OS almost 45 to 46 months. So even please go on, move on, because most of my slides has been discussed. Next. So next. So using the best drug, we have option of using first generation TKIs, second generation TKIs followed by osimertinib, or upfront third generation TKIs like osimertinib. Next. So first of all, I will discuss the third generation TKI, the osimertinib. FLORA data already has been discussed. Please move on. Complete all the FLORA trials. Next. 5 slides next. Yes. So these slides already there is a structurally difference between the third generation among the between third and first generation. Gepitinib, erlotinib are aniline of quinazoline derivative, whereas osimertinib is monoaniline pyrimidine. It has the highest CNS penetration. It is irreversible EGFR TKI inhibitor. Next. Yes. So it is selective for EGFR TKI sensitive mutation, both L858R and exon 19 as well as T790. Next. This is the FLORA trial already discussed. Next. So FLORA PFS 18.9 versus 10.2 months, and you can see the incremental benefits, and this is subgroup efficacy of osimertinib across clinical subgroups. Next. OS also similar, though L858R group they didn't get much benefit. Also in other trials, this subgroup of patients they do poorly. Next. Then first generation TKI, even our some Indian data, almost these are the trials, Indian data, and you can see the median PFS with EGFR TKI in Indian patient is almost similar to the reported in global studies. Next. Please go fast. I have already completed this slide. Please go fast. So this is Indian data. I have already told. Next. second generation TKI, especially after the Archer trial, dacometinib, though the PFS advantage almost OS almost 34 months, but there are several flaws in the trial, and it is more toxic. Even dose reduction required in almost 66% of patients, and it has excluded patients with CNS metastasis. Even patients with stable CNS, Archer trial excluded. OS, already this slide has been discussed. Next. So the trial had a hierarchical stratified design. So OS is not significant, though clinically significant. PFS 18.9 months in osimertinib FLORA, 14 months in Archer trial, and overall response 77 versus 75%. Median duration of control 17.6, and most important, you can see the dose reduction. 66% patients they require dose reduction, and only 3% in osimertinib, and serious adverse effects in 27% of patients. Next. So another trial, LOX-LONG-7, also it failed to improve OS. Next. This slides has been discussed. Next. So you can see, though osimertinib ideal treatment option of EGFR patients, including patients with risk of CNS, because osimertinib has highest CNS penetration, and you have already discussed about the CNS PFS of osimertinib. It is the highest among all the TKIs. Next. Also the CNS progression, it is 15% in the comparator arm, only 6% in osimertinib. Please go fast. I have already discussed. Next slide. So risk of progression or CNS metastasis is lower with osimertinib in comparison to the gefitinib or erlotinib. Next. This slide becomes static. Please move on.
Not moving.
Yes.
कुछ लोचा है आज स्टार्टिंग रू आज प्रॉब्लम चलछि
Yes.
I mona rakhichon jodi koi diontu.
So if we compare the osimertinib versus dacometinib, it has excluded the patients with CNS metastasis, and it is more toxic, and also the data hierarchical stratification required in this trial, though clinical significant OS was there, but it is not statistically significant. And osimertinib oral trial is the first trial, so OS benefit. And if we'll see the optimization, whether we should start a first TKI followed by osimertinib, or osimertinib first followed by chemotherapy, because if we'll start first general TKI, almost 1/3 of patients they will die due to disease progression, or they will lost to follow up. So if we'll consider starting a first or the second generation TKI, almost 70% of patients they may not able to take osimertinib either in first or subsequent line of therapy. So it is always better to start with the best possible drug we have with longest PFS as well as longest OS. So the PFS is almost 18.9 months, and if you use osimertinib in frontline setting, then you will get OS of almost 38.6 months, followed by chemotherapy. So you can go up to more than 40 or 45 months. Whereas if you use gefitinib, erlotinib, then the median OS you will get is almost median PFS is almost 15 months. So because if you start 10 patients, out of 10 patients, only 3% patients will be able to take osimertinib in subsequent line. Therefore, better to start the best possible option in the upfront setting. Also another trial, they have seen the geotag study where they have taken patients who has received afatinib followed by a osimertinib. They have OS of almost 36 or 35 months, but there are several flaws in the trial, even limitations in the trial. So better to start with the third generation TKI to get the maximum benefit. Thank you very much.
So thank you, Prashant. So I don't know, something happened. So we move to the last presentation by Dr. Jogmaya. So once somebody has progressed on EGFR TKI, so what to do? So management of NSCLC patients who have progressed on EGFR TKI. So Jogmaya, please.
Good evening. I will start my screen sharing. Please tell me if it is visible.
Yes.
It is moving.
Okay, I'm audible.
Yes, you are audible, you are visible, your slides are there. Please.
Okay. So, as we know, very important three most common oncogenic driver mutations in non-small cell lung adenocarcinoma are KRAS mutations, EGFR mutations, and ALK rearrangement. Most commonly, the EGFR KRAS mutations are the most common ones, and EGFR mutations can be seen from 20 to 40% of the cases. Asian population has mostly around 40% patients can show EGFR mutation positivity. So as we know that EGFR gene has the EGFR molecule has extracellular and intracellular domains. Extracellular domain has ligand binding and cysteine rich domain, and alternatively intracellular domain has a tyrosine kinase domain and a regulatory domain. In the tyrosine kinase domain, the genes which are mostly mutated in the EGFR mutated patients, they are usually stacked in this tyrosine kinase domain. They are mostly exon 18, 19, 20, and 21. Among the mutations of all these four genes, exon 19 and exon 21 mutations are most common. Exon 19 mutation is seen in 46% of the patient, and exon 21 point mutation of L858R mutation is seen in 37% of the patients. And as previously we have already discussed that various EGFR TKIs have shown benefit over the platinum doublet chemotherapy in advanced non-small cell adenocarcinoma lung carrying this driver mutation, EGFR mutation, that we have already seen. But all the EGFR TKIs, they work for 8 to 14 months, but after that anyhow the patient progresses. So after progression, the options include changing into a second generation EGFR TKI, subsequent chemotherapy, or a third generation TKI. So this is an unmet need, like what to be done after the patient progresses on first line chemotherapy. Now, EGFR T790M mutation is the most common mechanism of acquired resistance to EGFR TKI therapy. Almost 63% patients who have already been exposed to the primary or first line EGFR TKI experience T790M mutation, and this is the reason for their not working of the first line TKI. Other mutations are HER2 mutations, MET amplification, and transformation into the small cell lung cancer, which occurs in 3% of the cases. Now, potential mechanism by which T790M causes resistance are two. One is prevention of EGFR TKI binding. That means the T790M mutation results in substitution of a threonine to methionine at the gatekeeper amino acid and leads to a bulkier side chain. Because of this steric hindrance, the binding to the approved EGFR first line EGFR TKIs like erlotinib, apatinib, and gefitinib does not occur. Second mechanism is there is an increased ATP affinity of the EGFR. That means T790M increases the ATP affinity of EGFR, because of which because of the ATP affinity, it does not bind to the erlotinib and gefitinib. When they compete with the ATP binds faster, and erlotinib and gefitinib, they do not bind to the EGFR receptor. So this apparently reduces the efficacy or potency of this EGFR TKI. So osimertinib is a third generation oral irreversible EGFR TKI for metastatic T790M positive non-small cell lung cancer. It causes irreversibly inhibition of T790M mutation. It also causes other EGFR mutations like exon 19 deletion or L85R8R point mutation. It has lower activity for wild type EGFR, so prevents mostly the off-target side effects of the EGFR TKIs. It has lower affinity for the other receptors which can cause EGFR TKI resistance, that is insulin receptor or insulin-related growth factor, insulin-like growth factor receptor mutation. So osimertinib is indicated for patients with metastatic EGFR positive T790M mutation positive NSCLC detected by an appropriate test and whose disease has progressed on or after EGFR TKI. Osimertinib has a higher selectivity for EGFR mutation, than for the wild type EGFR, more selectivity for mutant EGFR compared to the wild type EGFR. So various sites or various guidelines, they have mentioned EGFR osimertinib as a second line of treatment of choice in EGFR TKI pre-treated patients on second line as a option for the best option for the second line therapy. So there are three trials of the AURA clinical development program, AURA 2, AURA 3. In this, phase 1, phase 2 studies were there in AURA trial, and phase 2 study was there in AURA 2 trial, and AURA 3 was a phase 3 trial, checking or testing osimertinib in the second line setting with prior EGFR TKI. So this we have already discussed. So AURA 3 is a phase 3 trial, and the eligibility criteria for AURA 3 was that more than 18 years patient, age more than 18 years, locally advanced or metastatic non-small cell lung cancer, and evidence of disease progression following the first line EGFR TKI, documented EGFR mutation and documented EGFR 3790 mutation positive, a good performance status 0 to 1, no more than 1 or 1 prior line of therapy, no prior neoadjuvant or adjuvant chemotherapy within 6 months, stable asymptomatic CNS metastasis were allowed. In this, they are randomized in 2:1 fashion, osimertinib 80 mg once daily and other platinum-based chemotherapy. Platinum-based chemotherapy was chosen pemetrexed plus either cisplatin or carboplatin up to 6 cycles, and optional maintenance for pemetrexed was also chosen. The primary endpoint was PFS. Secondary and other endpoints were overall survival, overall response rate, duration of response, the disease control rate, tumor shrinkage, patient-related outcomes, safety, tolerability, etc. So when they assessed the primary endpoint, PFS by investigators' assessment, osimertinib reduced the risk of progression of death by 70%. The PFS analysis was consistent also with the investigator-based analysis with a hazard ratio of 0.28. Median PFS in the osimertinib arm was 11 months compared to 4.2 months in the second line setting. And these patients were previously TKI treated patients. So the median PFS was 11 months in the osimertinib arm, 4.2 months in the chemotherapy arm. So with the impressive hazard ratio of 0.30, it showed almost 70% reduction or progression progression to death, progression or death. So overall response rate was also astronomically better, like in platinum-based chemotherapy. The disease control rate was better, and the median duration of response was better in 6 months, 9 months, and 12 months. When the safety analysis was done, the safety analysis showed that platinum-based chemotherapy, there are definitely little higher side effects were there compared to the osimertinib. Though because chemotherapy arm has definitely will have more side effects, grade 3, grade 4 side effects will be there. So osimertinib was safer compared to the chemotherapy administration, but certain side effects were more in the osimertinib arm, like diarrhea, rash, dry skin, and paronychia. All these were more in the osimertinib arm compared to the platinum based, the common TKI class effect. So these things were better, more compared to the platinum based chemotherapy arm. But others, like a common chemotherapy related side effect, nausea, vomiting, cytopenias, mucositis, all these things were more in the platinum chemotherapy arm. So the T790 mutation was detected in the plasma 50% of the patients with this, and when they found that the percentage of patients who received this osimertinib, who received this osimertinib, 51% sensitivity and 70% specificity of the T790 detection using the COBAS test as the reference, and it was tested both in tissue and in the ctDNA samples, and the results were more or less in agreement that both in plasma and the tissue the T790 mutation can be detected. So when they compared the progression-free survival in tumor T7 as a T790 mutation and in the plasma T790 mutation, they found that the hazard ratios were almost similar. That means either the sample is collected for T790 mutation from tissue or from the plasma. Osimertinib worked in both the things. In tissue, the hazard ratio was almost 0.3 for progression-free survival, and in plasma sample, it was 0.42. Both the curves were showing wide separation. So that means suggesting that either it is from tissue or it is from the ctDNA sample from the plasma. Osimertinib works in the second line after treatment with a first line TKI. So our 3 conclusion was that osimertinib demonstrated statistically superior, clinically meaningful efficacy over the platinum-based chemotherapy. Osimertinib was associated with lower rates of grade 3, grade 4 side effects compared to the platinum pemetrexed combination, but it has some class side effects which are common in TKI. So osimertinib is the new standard of care for patients with EGFR T790 mutation positive NSCLC following disease progression with the first line EGFR TKI. Now there is a real world asterisk study also, which has also shown that osimertinib is, this is the largest reported real world study of osimertinib in T790M positive NSCLC patients. It included 3,015 patients globally, and the median PFS was 11.1 months with a response rate of 57%. And the safety and tolerability data were consistent with the AURA trial, like that the AURA trial. So the AURA phase 1, phase 2 trials, there were dose finding and expansion cohorts. So there are pooled analysis, and in this pooled analysis, they have found that the disease control objective response rate was almost 66%, and disease control rate was almost 91% in patients who were treated with osimertinib. And AURA pooled phase 2 data showed that the progression-free survival and the duration of response, the median progression-free survival was 11 months and median duration of response was 12.5 months. So now the brain metastasis patients, almost in AURA trial, there are 234 patients with brain metastasis were included, and the patients who were, the patients, EGFR mutated patients were almost 64%, and patients with EGFR mutation had a higher rate of bone marrow, higher rate of brain metastasis at the initial diagnosis, and 16.7% patients had documented brain metastasis at the initial diagnosis in EGFR mutated patients. And in EGFR wild type patients, almost sorry, this was the brain metastasis in the initial diagnosis. Patients with other group also, patients with EGFR mutation had a higher rate of brain metastasis at the final follow-up. Incidence of incidence of brain metastasis in lung cancer are increasing, and the outcome of patients who develop brain metastasis are actually poor. And there should be improvement in the systemic cancer control, because brain is a sanctuary site. And rates of brain metastasis may be influenced by changing treatments. 25% of the lung cancer patients have brain metastasis, and 80% of the lung cancer patients surviving more than 2 years will eventually develop brain metastasis. And overall, the patients with brain metastasis, without treatment, the survival is less than 3 months, and with treatment, the survival may be up to 6 months. But brain metastasis, many cases, the brain metastasis has been found in lung cancer patients who have died, and autopsy results have revealed that brain metastasis which were not diagnosed clinically. That means they were asymptomatic brain metastasis. So there are some evidence of shrinkage of brain metastasis in patients treated with osimertinib. So patients, PFS benefit of AURA3 patients with CNS metastasis at baseline. Patients with CNS metastasis, the treatment with osimertinib compared to the platinum pemetrexed improved the survival, improved the progression-free survival. Like the hazard ratio for progression is 0.32 for patients with CNS metastasis. For patients without CNS metastasis, the hazard ratio of progression in osimertinib versus platinum-based chemotherapy is 0.42. So with a very impressive hazard ratio in patients even with CNS metastasis. So in summary, osimertinib is an oral once daily reversible EGFR TKI for metastatic T790 mutation positive NSCLC adenocarcinoma. It has demonstrated statistically superior, meaningful efficacy over the platinum pemetrexed chemotherapy, and robust efficacy has been found in various subgroup of patients, including CNS metastasis, symptomatic or asymptomatic metastasis at the baseline. Safety profile is consistent with the prior, whatever previously detected, seen in clinical trials. The real world data also in concordance with the safety data. Osimertinib is the new standard of care for patients with EGFR T790 mutation positive lung cancer patients following a disease progression with the first line EGFR TKI. Thank you. Thank you for patient listening.
So thank you, Jogmaya. So anyhow, so today we have overshooted by almost 30 minutes. Initial group up, poor network spoiled the sport, but anyway, so there were lots of learning. There is a good news from AstraZeneca that besides get a coupon for EGFR and T790 first line, second line, so they are already planning to get a coupon in a resected specimen also. Second, so Priyam will just share that, so they have come with a lower price for osimertinib. So that's a good news, but still that's quite high for our patient population. So maybe time to come, so we'll see more revision of price, because we understand that in the EGFR space, so osimertinib is still the number one in all respects. So thank you, friends, for this joining today's meeting, and over to Priyam for our closing remarks.
So thank you very much, all the doctors, especially Ghanshyam sir, Jogmaya madam, and all the doctors who have attended. Thank you very much for patient listening, and we plan to have many more like that. I'm really sorry for the technical goof off, but next time I'll keep that in mind. Sorry, sir.
So thank you, Priyam. Thank you, Horizon, for the coordination today. Thank you so much. Stay safe. Take care. Good night.
Thank you. Good night.
Good night, sir. Good night.